Thanks very much. Thank you. Well, thank you very much, and it's a real honor to be here in Tom Watchel's name. He was a friend and colleague, co-trauma director in the San Diego County Trauma System, and a fellow Navy surgeon. So it's with a great deal of honor and respect that I come to you today. Tom was a great guy, those of you who knew him, filled with compassion, professionalism, hence the topic of this talk really reflects who he was and what he brought to all of us. As you know, he had a tragic accident on the highway, left him quadriplegic, but even in his quadriplegia, he was inspirational in training himself to use what was left and never lost his incredible spirit. Well, first of all, let me establish my credentials. Okay, so I used to say Webster's, but nobody has a Webster's dictionary anymore. So every online dictionary will say that you need to be very skillful, having much training and knowledge in some special field. Well, I'm the oldest of 9 boys, big Irish Catholic family. By the way, you guys know what Irish Alzheimer's is? Everything goes but the grudge. Anyway, one of my brothers says Irish equilibrium is when you got a chip on both shoulders. So a bunch of my brothers in college put together Sise Brothers Painters and Roofers until they dropped a bucket of tar down the side of a house. So they got rid of the roofing. But they said, if we've read about it, we're experts. And then finally, the trauma definition is if you're from out of town, talk fast, and show slides. So hopefully I'll qualify. So my real worry in preparing for this talk was, what the heck am I going to talk about? So I decided to go to the literature. And I have a reliable source I go to every day, and that's Wikipedia. So, Wikipedia says bias is an inclination of temperament or outlook to present or hold a partial perspective and a refusal to even consider the possible merits of alternative points of view. And that people may be biased towards an individual, a race, a religion. They can be one-sided, not having an open mind. But the important part of this is partial perspective. Even consider possible merits of alternative, not having an open mind. Well, let's take a look at what that means. The American College of Surgeons that we all pledge to, but also the American College of Surgeons is the group that comes and inspects your trauma service, basically points out that in their pledge, and you don't take a pledge in something that's easy. You take a pledge because so many people have violated the thing you're pledging to do. Pursue the practice of surgery with honesty and place the welfare and rights of my patient above all else. Deal with each patient as I would wish to be dealt with if I was in that position. Respect the patient's autonomy and individuality. Okay. I get a 17-year-old African-American male, gunshot wound left chest, drive-by at a party. Pre-hospital, asystole, over 15 minutes of CPR. He arrives, he's cold, no pulses. We put a probe on the precordium, no cardiac activity, and it's been a good 25 minutes. In fact, there was an attempt to declare him dead at the scene after 15 minutes to 20 minutes of CPR at the scene, but it was a hostile scene, and as you know, we transport in San Diego County, I mentioned, do the same thing. All children, nobody gets declared on scene if there's a child. And if there's a hostile scene, you transport. He was clearly dead. So he looked like just another gangbanger. And he was a valedictorian of his class at a parent-supervised non-alcoholic event that gangbangers tried to crash, got turned away, came back, shot it up. He had a full scholarship to Cornell. He was the pride of his community. A community center now bears his name. I was devastated when I realized my bias. 29-year-old male skateboard crash, intoxicated, abrasions, deformed wrist, 5-minute loss of consciousness, covered in tattoos. He's got a nose ring. He's thin and extremely short hair. You recognize this guy, right? Looked like just another meth-using loser. Mom was one of our nurses. He's in community college, close to being a paramedic. The politest, patient, thankful, unapologetic, and totally sober patient. Whoa. So, what about this bias thing? Okay. Well, the sources are gender, sexual preference, race and ethnicity, culture, psychiatric illness, lifestyle and body habitus, politics. Politics. What about politics? I don't know about you, but at Thanksgiving dinner, I'm not going to talk about politics. I am not going to say boo. And there's been a lot written about how all over the country, people have stopped talking about politics because they're fighting words. Tobacco, drugs, and alcohol, economic factors, et cetera, et cetera. It is profoundly human to be biased. We're hunter-gatherers. And if the tribe over the hill, who tied their hair in a knot on this side, and you tie your hair in a knot on this side, showed up and killed a bunch of your bros and stole the women, next time you see somebody with knot on this side, you're going to be ready to fight. It is intensely human. Intensely human. And it turns out that in trauma care and in health care in general, right now, obesity is the number one cause for bias. Number one. Now, that's based on how difficult it can be to care for folks who are obese, what it does to your physiologic response, and there's almost a collective groan when somebody really heavy rolls into the trauma bay. So bias is in there. And the question is your hospital a place of refuge or sanctuary from the perils of life? Wikipedia, again. By the way, I love Wikipedia. Defined as a sacred place, such as a consecrated area of church or temple, the meaning was extended to places of safety. Many ancient peoples recognized a religious right of asylum protecting those accused of crime. This principle was adopted by the early Christian church, the sanctuary around the altar from the 4th century on. If you got there, the king could not touch you. And in fact, there was a city of refuge in ancient Israel, and those of you who've been to Hawaii know there's the place of refuge on the Big Island. The Hawaiians were brutal. They were Tahitians who wiped out the indigenous people when they showed up. If the king's shadow fell on you, you were dead. I mean, that's how ridiculous it was. Unless you made it to the place of sanctuary, and then you were forgiven all your sins. Well, our hospitals are places of sanctuary, in reality. And that means managing bias. I promise to deal with each patient as I would wish to be dealt with if I was in the patient's position. Beware of bias when anyone who's different than you shows up. It is part of our nature to be biased, but it has to be managed, especially if they're obese, crazy, intoxicated, or vulnerable in any way. Of all people, when I was a third-year resident, I was rotating on the urology service. And back in the day, as all guys, full disclosure, I'm 69 and a half. Okay, I'm gray on the inside. But all guys at the time, women had not really, now it's 50% women in surgery programs around the country. So this hard-charging, cigar-smoking Irishman said, boys, if a patient makes you angry, they're crazy. Turn on your crazy management mode. Best advice I think I've ever heard. The minute you start getting angry at a patient, say, whoa, this man or woman is crazy and or intoxicated and or turn on your crazy management mode and turn down your bias if at all possible. But bias is in there. It's like a tiger. It waits for you. So this is an active process, and I know you all know it. You all feel it. You got to get on your A game. You got to get on your A game and turn on your compassion. It involves allowing ourselves to be moved by suffering and experience the motivation to help and alleviate and prevent it. Qualities of compassion are patience and wisdom, kindness and perseverance, warmth and resolve, ranked a great virtue in numerous philosophies. Compassion is considered in almost all major religious traditions as among the greatest of values. And every faith tradition considers your value measured by how you treat the least among your society. Every faith tradition. So I get consulted to the MICU. I've been on trauma call the night before, got about 2 hours of sleep. It's about 5 o'clock in the afternoon. And, I'm chief of the medical staff, which means all day I got to deal with my colleagues who aren't being super professional. I'm the prefect of discipline. It used to be men behaving badly, but now it's gender neutral. Men and women physicians frequently have to be reminded. As And those of you who are nurses certainly know that. But I get called to the MICU. I'm on my way out the door, and there is a 75-year-old woman on 3 pressors, bad pneumonia, and she has cold feet. Well, she's got cold feet because she's on 3 pressors. I walk into the room, and there's 2 daughters standing there like this. And I'm looking around, and I'm thinking to myself, this lady needs to be allowed to die. I'm just a consultant. In fact, she doesn't even have vascular disease. She actually has Doppler flow. But she's all clamped down from the 3 pressors. And I just wanted to say, well, there's nothing for me to do, but damn, I can't leave this. So I got on the phone to the pulmonologist. I got on the phone to the medical teaching team. I said, this lady is dying, isn't she? What about comfort care? Well, but nobody had taken ownership. And I'm the consultant. So I walked back in, and I've been part of something called Second Trauma, which is teaching compassionate communication. And I remind my students and residents that your everyday world, where you love to be, is your patients and their families' worst nightmare. When you walk down the hall, you're in a bubble of satisfying professionalism surrounded by people who are absolutely living a nightmare. So how do you tell this family? Because at its best, it's bad news. There is evidence that works, and let's focus on the trauma ICU. Establishing and maintaining effective communication is how we're compassionate. Do you know that a mature troop of chimpanzees, not under stress, spend as much time grooming each other as humans in a stable population spend talking to each other each day? It is our talking to each other is social commerce. It is how we are human, without a doubt. The ICU challenges, taking care of the injured may be the easiest part. Communication is more difficult in survivors, and the longer they live, the harder it is to maintain good communication. When it's time to talk to the family, what should your goals be? Well, effective communication, get your story together. Understand exactly what happened. Don't roll in and be wrong about anything. You need to tell that story effectively, including figuring out who's seen the patient, what's happened. Choose a spokesperson in the family once you engage the family, whoever that's going to be, and then assess the family status. And all of us in trauma have to deal with blended families all the time. It was nothing worse than having this, and living at the border in San Diego, having this originally Mexican resident who moved to the United States, got injured, had a wife in the United States, had another family in Mexico who showed up. That was interesting. Set reasonable expectations, focus on ICU coping, establish schedules. And walking by and doing what I like to call a drive-by does not constitute effective communication. Updates and then call for a care conference and don't be late. If you say you're going to be there, be there. If you can't be there, call up and say to the ICU nurse, please let them know I'm stuck and I'll get there as soon as possible. And anticipate changes. There's a critical illness ebb and flow. Family factors intervene. Physical space limits, we have lousy care. I actually go out in the hall and sit on a radiator. I'm in an old Catholic hospital. It's about to be rebuilt. I sit on a radiator so I'm at eye level or below in the hall and get them together in a quiet space. My first interaction with family, I always tell them, it's not like TV. We don't come to you and say, is it thumbs up or thumbs down? Heaven forbid, should things go poorly, we'll know. We let you know what we know, and we let your loved one tell us by how they're doing what the right thing to do is, and it will always be apparent. So please don't worry about that. We're not going to come to you. First conversation, it's essential. Multi-specialty care, if the neurosurgeon tells he's going to get up and walk, and you're looking at him, what are you talking about? So you have to make sure that you're all on the same page, all have the same approach, and all are telling the same story. Complication errors happen, and you have to let them know. There was a paper written, never say you're sorry. You don't say, I'm sorry, and for what? You say, I'm sorry for your loss. If it could only have been different. Despite our best efforts, this is what happened. This is what we've got you to do to get you out of trouble. In fact, when I prep my patients for any kind of surgery, particularly open vascular surgery, which can be treacherous, I say, all I can promise is my best effort. I tell them what might happen. If you develop a problem, I'll tell you about it right away and what we got to do to get you out of trouble. And I'll stick with you no matter what. They know that trouble means complications. And if you tell them up front and deliver on that, they will forgive you just about every error, as long as you tell them about it. Despite our best efforts, I sucked the vein graft up into the suction device, and I had to use Gore-Tex. That actually happened to me one time. Resident moved the suction device, vein graft I spent an hour harvesting carefully, went right in the bucket. So, how am I going to tell them about this one? Well, the vein wasn't working so well, and unfortunately it got contaminated. But, and then you have managed care issues. You've all seen it. You bond to a patient, they bond to you, boom, they're gone to Kaiser in San Diego. And you've got to do a good handoff. Those people are so good. They work so closely with us, you're going to get great care, even though you just want to take a swing at somebody for stealing your patient. And then medical legal factors. So, anyone can do the easy ones. Every setback needs explaining. Family situations evolve and fatigue sets in, and some die a slow and ugly death. No two ways about it. And you gotta, I think the older you get, the more you bring your own experience and you share it if it's effective. I lost a brother. The three of us were in the Navy. My youngest brother was a Navy pilot. My next oldest brother was a Navy SEAL. And then back in the day, he was in the CIA. So funny. He was in the Africa division. He said, I hate those Russians. But he unfortunately got a brain tumor, same tumor McCain had, and died of a post-op complication, which in retrospect was probably a blessing. He never would have tolerated a slow death. But I've been on the other side of this. And then I lost my mom, and my dad. So, we bring that to the situation, and I can honestly look at them and say, I've been where you've been. I know how this feels. It's not easy. Consensus for comfort care, and that's what I faced in this consult. Troubleshooting, complications, errors, family conflicts, substance abuse, psych issues in the family. Oh, that makes it complicated. I had a patient who, it was a horrible death. A young woman in her early 20s pushing her baby in a stroller on a surface street with a rise. A sport utility comes up the rise going too fast. She pushes the stroller out of the way and gets clobbered. She comes in, she is like every bone is broken. She's dead. She's cold and dead. No cardiac activity. So let's get the family together. We made a big mistake. We put them in the chapel. We've got this beautiful little chapel right off the lobby. So in the front row is the young husband. Back row are uncles and brothers. Community police officers in the back. Police officers are around. I sit down. I pull up a chair. I'm sorry to have to tell you your wife died. He jumped up, punched out a stained glass window, jumped on a cop, grabbed his gun because he wanted to shoot himself. I stood up. Well, that didn't go so good. Just sometimes it doesn't work. Fortunately, they arrested him, handcuffed him, and then released him. Oh, in the back row, we had security and community police officers. The family turns around and starts wailing away on it. It was like something out of a, Jerry Springer show. That didn't go so good. And in the debrief afterwards, we're not going back in the chapel. For about a month, there was a piece of plywood over this beautiful stained glass window. So, back to the ICU. So I'm looking at the two daughters like this. I pull up a chair, I sit down, I say, and you always want to be at eye level or below. Lean forward, I said, I've talked to everyone involved, and I've been where you've been. So, because my mom had a big peri-op MI during a knee replacement in her late 80s and just about died. But, she hadn't been screened. She had a brother who had a cabbage at age 41 and nobody screened her. In any event, I said, I've been where you've been. I know where you are, and I think your mom's trying to tell us that her time has come. And it's time to stop. I let her die with dignity with you with her, and they just relaxed. Oh, thank you so much. And we spent, I spent a good hour talking with them and explaining and, and They said, well, I hope your mom's doing okay, as I left. And I walked out to the car, exhausted, and thought, maybe I have more to give. Maybe I have more to give. I don't know. It was certainly the most important thing I did that day. So, and that's what Tom used to do. That's what Tom used to do. So the goals, again, are to thoroughly inform, direct family efforts, begin healthy coping, initiate the grief process, but remember those goals. And, you know, it's so, especially if you have to give a death notice. You know, there's a family in there, still hoping. You're walking down the hall carrying an emotional sledgehammer that you're going to hit them with. And you just pause at the door and remember your goals. That's the best you can do. You got to create a bond of compassion. You've got to let them know that you appreciate how they feel. Now, if you've been on the other side, you can say, I know how you feel. I've been there. Or I can only imagine how hard this is. When I round on my vascular patients, I tell them, hey, I'm trying to end this hostage crisis and get you discharged. And the patients love it, because being in the hospital is being a hostage. Actually, we call vascular rounds counting toes, because they're all losing their toes from diabetes. So professionalism, the last part of the triad that we're talking about, and really, again, dedicated to Tom Watchel, who was a consummate professional. Middle English for profess, having professed one's vows. As people become specialized in their trade, they profess their skill to others and vow to perform the highest known standard. Most professionals are subject to strict codes of conduct, enshrining rigorous ethical and moral obligations. Some definitions limit this term to those that serve some important aspect of public interest in the general good of society. And basically, the social contract is that as doctors and nurses and healthcare providers, we are given autonomy to practice, to have people come in and take off all their clothes and bare themselves to us in return for us holding ourselves to the highest standard and policing ourselves and making sure that we deliver on that commitment. You know, I tell the pre-med students, I have at the University of San Diego, I have a pre-med, I'm actually an instructor in the Department of Psychology. One of my friends said abnormal psychology. But I tell them, you know, you're asking to go to medical school, you're asking to be given autonomy and total decision-making over someone else's life, and you're going to be held to the highest standard. You can't have a DUI. You lose your license. And you just need to understand that to be a professional means these things. Vow to perform to the highest known standard. Well, you know, to my surgeon friends in the audience, did you train under this guy? And Dr. Steve Shackford, good friend and colleague, likes to say that to make a good surgeon, it takes a good set of hands and a closed mind. Actually, to make a good general surgeon, it takes a good set of hemorrhoids, gives you that concerned look. The surgeon's perspective, you know, we are certain that we know the way. We don't like to be wrong ever. Ever. We don't, you know. The old saying, right or wrong, never uncertain. My wife and colleague Beth is a nurse attorney who runs our research program and an injury prevention program at our Level 1 center. She likes to say, right or wrong, frequently mistaken. So, how certain were we in the past and how wrong were we in the past? I cut out large sections of stomachs in people with ulcers for an infectious disease. The guy who found H. pylori had his article rejected by 8 journals. He finally gave himself an ulcer by giving himself H. pylori, and he's won a Nobel Prize. Now, on the other hand, there was a Nobel Prize granted for frontal lobotomy. So, you know, minimally invasive surgery, we almost let the GI guys, they were mainly guys back in the day, do laparoscopy. The only people doing it when I was a resident was OBGYN, and we kind of poo-pooed it and almost didn't pick it up, and now it is core to all general surgery to do laparoscopy. Endovascular surgery. Everybody I see now gets a stent until proven otherwise, and rightfully so. We used to make big incisions. It was a lot of fun. Big surgeons make big cuts. Not anymore. Non-operative, think of all the spleens we took out, we didn't have to take out. Think of how many patients now we don't have to operate on. And how many of you participated in iatrogenic saltwater drowning back in the day, slamming in the lactated ringers and the saline, occasional blood. And now we know how wrong we were. Remember back even 15, 20 years ago, all that ARDS, which has disappeared, shock lung? It wasn't shock lung, it was iatrogenic saltwater drowning. We know now when we give 1:1:1 or whole blood if it's available, our patients jump right back up again. So we've been so wrong in the past, it's striking. So what's next? What are we doing today that is just totally wrong? Surgeon changes their minds, that could happen? Well, yes, it can. So my worst worry is, am I getting better or am I just getting older? And, you know, it's interesting. I have a talk that I've given in the past about learning to learn. When you come out of residency or nurses training or wherever you got your core initial education, you are so convinced that you know it. It's like religion. And you have to unlearn it. And it's so, I ran a very active trauma group, and I had partners join me over time. And it was so interesting to watch them be so convinced that the way their professor taught them was right, and watch how long it took for them to change, adopt. On the other hand, I had been at this so long. I used to tell my guys, the men and women I worked with, my goal is to be worthy to take trauma call with you. I had to relearn everything, and I learned everything I could from them. So learning to learn. And do I have to learn everything the hard way? How do I keep from losing my edge? And I've had to ask myself this question, and I must admit, about almost 15 years ago, I'm in my mid-50s, and I have some complications. Oh my God, it's not going to get any better. So let me tell you a cautionary tale. So this is a ribbon origami that hangs in my office, given to me about 12 years ago by a patient who is a World War II Japanese war bride. And in the occupation after World War II with American troops in Japan that went on for quite a while, there were a lot of romances. And there were a lot of GIs who married Japanese women who then immigrated to the United States. And it's a fascinating tale. It's a great piece of diversity and part of our culture. And she made me this ribbon origami. Well, the story is a lot more complicated. It's a near miss. I'm operating along, 64-year-old woman, undergoing carotid endarterectomy, and it's the spend a day with a nurse day that many hospitals will do, where the administrators hang out with a nurse all day or a respiratory therapist. So one of my friends who'd been an administrator I'd worked with in the past, who'd moved up to the Scripps system, is hanging out in the OR with us, and we're chatting it up, and I'm doing a carotid endarterectomy with a resident, and I use a shunt on all of them. So I say to the anesthesiologist, when we get to 50 minutes, 50 minutes, give another dose of heparin. It's like 40 minutes right now. He says, we haven't given any heparin. I forgot to give heparin. I got the artery clamped, and then I slid in a shunt. My stomach fell through the floor, fell to the basement, 4 stories below. I thought, I killed this lady. So took the shunt out, gave her a big dose of heparin, took the shunt out, did a gentle Fogarty thrombectomy. She did great. She did absolutely great. So I was shook. And, the traditional professional trajectory, whether you're a doctor, nurse, fireman, whatever, lawyer, is thought of this way. Okay, you kind of peak and then you start to decline. And I asked myself, is this me? This is back in 2007. I'm 57 years old. And I talked to my brother, Bernie, who, this is the two of us together at the end of the Gulf War, who's now a Delta pilot. I said, I can't believe what I did. So he said, well, do you use a checklist? Well, I said, no. I said, well, you'll do it again. I said, what do you mean? You'll do it again. You'll absolutely do it again. And he said, we now do risk management. Not like we do risk management, which is basically cover our butts legally. But the airlines admitted back a decade and a half to 2 decades ago that they were flying as if flying was inherently safe. And instead, they embraced the idea that it's inherently dangerous. And that you have to brief each flight. What are the risks to this flight? Has this crew worked together before? Are they at the end of their cycle? Are they due for rest? What's the status of the aircraft? What's the status of the weather where we're taking off? What about the route? What are the risks during the route? What are the risks landing? Surgery is inherently dangerous, and yet we behave as if it's inherently safe. So, 3 common factors in every airplane crash and every major medical screw-up. Familiarity, I've done a lot of these. Distraction, and some element of fatigue. Well, I've done 1,000 carotid endarterectomies. I was distracted by my friend in the room. I hadn't been up the night before, but that would have made it worse. I have a sailboat. You know what BOAT stands for? Bust out another 1,000. And I single-hand it. It is inherently dangerous. I've been injured 4 times on it over the last decade. My wife said, any more, you're done. And it's an inherently dangerous, and errors are expensive, and I have checklists, and if I don't follow them, it costs beaucoup bucks. So I'd already figured that out because of the money it cost me to screw up. So I put together a carotid end artery checklist, give 5,000 units of heparin, and I give a copy to the anesthesiologist, a copy to the nurse. I have this for all my major operations. I hang a copy on the IV pole that I can look at. And I give it to the residents as a teaching tool. And everybody likes step 15. Now, I actually sent all my checklists to Atul Gawande, who you know wrote the checklist manifesto, who I know through one of the professional organizations. So I took that last step off as being a little bit proud. Everybody in the operating room said, where's step 15? So I put it back on, because that's what we want. And on our worst day, we tried to help somebody. Our worst day. So the professional directory can be quite different. It can be quite different. I totally changed my approach to operating. I know I'm going to make mistakes. My goal is to mitigate them, to recognize them. Back when I was in training, we used to call them FUIPs, F-ups in progress. And if they were averted, FUAV, if they took active step, it had to be aborted. Aborted, and then if you completed it, it was an FUC. So we'd already recognized that you have to mitigate it. You know the difference between the best performing hospitals and the least performing hospitals is not the number of errors. It's the error mitigation, interception, and aversion or active steps to stop it. It's an inherently dangerous thing we do. Experienced surgeon, next day after trauma call in the OR for vascular repair, misses the anterior compartment fascia on fasciotomy. Patient is left with a severe deficit, ultimately loses his leg. At trauma M&M, he's flogging himself, blah, blah, blah. I said, wait a minute. We've done this before. Could you advance the slide? This happened 2 years ago. So I focused on the fatigue, the familiarity, and distraction, and the use of a checklist. And I now have a checklist that includes probe under the fascia to the tibia to assure there is release of the anterior compartment. And I use that every time I do a fasciotomy, and I've recommended it to my colleagues. Well, this is definitely me, and it has to be all of us. If you've been on a job for 3 to 5 years, you are an old dog. Just saying. You got to learn new tricks. No 2 ways about it. Whether you're young or old. It gets a little harder when you're older unless you take some heavy hits and figure out what you got to do to stay in the game. And, you know, older can mean wiser. These are some of my nurses. You can't stay too flexible. I'm proud of it, I might add. Old school versus sensitive new age guy. That's my goal, be a sensitive new age guy instead of a stodgy old fart. So, acknowledge your limitations, read relevant resources, go to good conferences like this one, listen and learn, identify the thought leaders, the people you want to bounce things off of, rethink your entire practice constantly. Refresh. Assume there are things we're doing now which are wrong and can be improved. Learn from aviation and sports. I think that what we do is a lot less like flying an airplane and a lot more like professional athletics. I think we are all trying to be a Tom Brady, to pull it out in the red zone. Baseball has hits, runs, and errors. You can't win every one, but you can learn from every one. The marathon runner has no The professional marathon runner has no runner high. He or she is thinking about how they're striking, how they're breathing, how their hips feel. And if they win, they go back and say, okay, how did I almost lose? What did I do that almost cost me that win? And what do I do differently next time? That's what we have to do. Consider checklists and remain humble. I mean, my contention is if you do what we do, what I do, and you're cocky and confident, you have a profound learning disability. Profound. This is an essential task for all of us. Active process with structure. Be determined and committed. Leave no stone unturned in looking at your practice. And, you know, we need to calibrate ourselves. Embrace our complications. Be all in all the time. Remain humble and honest. None of us is as smart as all of us. We really need to learn from each other. And the last rule, I think, is that we've arrived when we embrace the diversity, reach out and find some connection with people that we aren't like, to let them know that we are concerned about how they feel and are trying to give their loved one back to them, trying to end the hostage crisis. And that every day we do that by finding our A game, just like a professional athlete. I'm convinced that is really the valid model. And just like every overly proud professional athlete, they go down in flames. We need to remain humble, but confident of what we do, analyze our processes, and learn. Feel free to send me an email if you have any questions. And thank you for the honor of joining you. Tom was a dear friend and colleague, and I know that he lives in all of us in our commitment to avoid bias, be compassionate, and develop our professionalism. Thank you.